The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So why should hospitals invest in patient safety? So clearly, first, do no harm. There are a few important concepts to think about when you think about patient safety. The first is patient harm, and I'm going to go through a definition of patient harm in a second. Complications versus side effects, adverse events, preventability, and risk adjustment. Now, patient harms any unintended or unnecessary harm resulting from or contributed to by healthcare. Now, that's different to a side effect, okay? So, and it's important to this is something that healthcare has contributed to as opposed to something that just happens as part of a disease process. And that harm includes the absence of doing things. So if you don't make a diagnosis, if you don't do an investigation, if you don't do a procedure, you've caused patient harm. Patient safety is the reduction of the risk of unnecessary harm associated with healthcare to an acceptable minimum. And the word unintended there is really important. And it serves to distinguish between adverse events and complications, as I said. No healthcare intervention is completely without the risk or devoid of risk. And so what we're trying to do is minimise adverse events that are caused by the way the healthcare is delivered or not delivered, as the case may be. Now, there are all sorts of common types of adverse events. So medication errors are a typical one. So having an anaphylactic reaction to penicillin when you're known to be penicillin allergic would be a great example of an adverse event. Healthcare-associated infections are another example of adverse events, as are falls, and you're getting a picture here that this is in fact most of the things that are in the National Health Service Standards, and so the Health Service Standards attempts to capture patient harm. And as clinicians, what we have to do is try and minimise that harm, and if necessary, mobilise finances to minimise that harm. Now, not all of adverse events can be prevented, given the knowledge base at the time. So, for instance, an allergic reaction to a drug administered for the first time is not preventable because you didn't know they were allergic to it. However, if you gave it again, that's definitely preventable and would be an adverse event. Now, in the future, who knows, we may have a genetic marker for penicillin allergy, and it may be possible before you get given the penicillin to detect the allergy. And so in the future, it might be that a first dose reaction to a drug, which is currently not an adverse event, might in the future be an adverse event. So preventability is an important concept in harm, and the reason why I'll show you in a minute. So why should hospitals invest in patient safety? First of all, there's a moral argument. Patient harm has an unnecessary deleterious effect on patients, and that cost is the 14th leading cause of global burden of disease. So we, as clinicians, are responsible for the 14th most important disease affecting the world. Causes a huge financial burden, and as you heard in the first talk, between 10 and 15% of hospital budgets and health care is wasted fixing adverse events. And most of the adverse events are a few described, well-known events that you can do something about, such as healthcare-associated infections, venous thromboembolism, precious injuries, falls. So it's not as if this stuff's rocket science and we don't know what it is we have to affect. But some of these things aren't completely preventable. So even if you were on appropriate anticoagulation to prevent a DVT, there will still be a low incidence of DVTs. So they're not all completely preventable. Now, a set of adverse events that are said to be completely preventable are so-called sentinel events. Now, sentinel events were a list of adverse things that could happen to a patient that was described in about 20 years ago, and they're like never events. And some of them, because the list was described 20 years ago, actually aren't all that preventable. So, for instance, one of them is, say, suicide of a patient in inpatient unit, procedures on the wrong patient or body part, that is preventable, causing death or permanent loss of function. But things like maternal death associated with pregnancy is no longer thought to be preventable because lots of women at high risk say with cystic fibrosis. Our hospital's got a cystic fibrosis centre. Lots and lots of women choose to take the risks of having a pregnancy, despite the fact that they're told there's significant risk from the association of pregnancy and their cystic fibrosis. So at the moment, this sentinel event list is being revised, and in the next round of federal funding, the federal government is not going to put its 40% of hospital money into your hospital for a sentinel event. Okay, sentinel events will not be paid for. So one of the things the Commission looked at doing was using routinely collected hospital data to improve safety and quality. And the reason we did that is that the data is already collected. It's coded data. It's all there already. So you don't need another person with a clipboard. You don't need a clerk entering anything. It's already coded for us. And the idea was that this was a rich data source to feed back to clinicians for peer review and for benchmarking to improve safety and quality. One of the things the Australian case mix system has that isn't in the US case mix system is this thing called condition onset flag. And the condition onset flag tells you whether a condition was there on arrival at hospital or not. So, for instance, you might be admitted to hospital for urinary tract infection, or you might develop a urinary tract infection during your hospitalisation. And the condition onset flag detects that. And that's important because, as I say, then you can work out whether an adverse event occurred prior to admission or during admission. So we formed a working party to start to look at hospital-acquired complications and see whether you can make any sense of them out of the admitted data. We did a literature review and an environmental scan. We got a group of clinicians together to look at preventability, patient impact or severity, health service impact and clinical priority of a whole series of different potential lists of hospital-acquired complications. And we ended up with a list that I showed you the first half in the first session, so things like respiratory complications, respiratory failure, aspiration pneumonia, DVT, GI bleeding, medication mishaps, delirium. And we tested this in 5,000 medical records by recoding 5,000 medical records, and then just fed the data back to clinicians and said, is this useful for you? Now, most of you won't be surprised to hear that the surgeons thought it was a whole heap of crock, and they didn't think it was at all useful to them to know that they had an incidence of DVT of 30%, and a couple of people had a PE, and someone else had a major GI bleed. They thought they already knew all that. But the physicians thought it actually was quite useful and would inform their M&M meetings and inform quality improvement within their units. They were the hospitals we tested the hypothesis in. Now, and I showed you this slide before, when we looked across age groups, there's plausibility, the yellow's infection, high rates in young children, then going down, but then escalating infection rates as you age. This blue's delirium, and that's cardiac complications. So it looked like it was a plausible list. And the Commission was about to implement this in a voluntary way for hospital feedback for frontline clinicians. As I said before, it adds significantly to cost. So length of stay without a hack is 4 days, and with a hospital-acquired complications, 14 days. So it's pretty significant, pretty plausible, and a great little list for a lot of clinicians to think up. Then came along the last election. Now, before the last election, Turnbull had a meeting, a COAG meeting, which is the Council of Australian Government, with all the First Ministers. So the Prime Minister and each of the Premiers got together, and the Commonwealth put $4 billion extra health funding on the table, but said we want to send the system a safety signal. And what they decided to do was include our HACs, hospital-acquired complications, into the ABF system. Okay? Now, the way we're going to do that is by not paying for sentinel events and by risk adjusting the hospital-acquired complications after we look at preventability. So, for instance, if you're a hospital that is a trauma hospital, or you're a hospital that does neurosurgery, you're likely to have a much higher rate of DVT than many other hospitals. So there has to be risk adjustment, both for case mix in the hospital. But in the end, there's going to be a small risk-adjusted pricing signal to your hospital around hospital-acquired complications to try and drive down hospital-acquired complications. Now, there's $160 billion spent in our healthcare system, and that 40% of that is spent on hospitals, with the bulk of it in public hospitals. And the 60% of the funding comes from the state government, 40% from the federal government. So out of that $161 billion, sending a signal to the system to try and improve safety by decreasing hacks is probably a sensible message, even though those hacks aren't completely preventable, and even though lots of us find it offensive that the hospital might not get paid for a complication. Nevertheless, putting it into the ABF system is sending a signal that safety and quality matters, and provided the financial burden is low, we think that that's probably a sensible thing. And there's bucket loads of money if we can only redistribute it properly. Thank you.